We have patients like this. This patient was operated in a teaching hospital. Right hemicolectomy done. They reported it as T2N0 because the nodes that were dissected did not show metastasis. We did a workup. Primary wise, there is no problem at all because they did a good hemicolectomy as far as the colon is concerned. We did a PET CT on this patient. Patient has multiple nodes. Primary site also there is disease. There is uptake because of inflammation. CA was normal. Lymph node shows histiocytosis, no metastasis, accepted. The number of nodes was a problem. This patient was sent to Senthil Rajappa, who is a little more abnormal than me in terms of telling the truth when it is necessary. So he called it T2NX and sent the patient back to me. Now what do I do? On the 13th postoperative day, hemicolectomy done, there is an anastomosis there. So much more difficult to go back and actually stage this patient in an endometrium or a cervix or anything like that. It's so much more easier to do a staging lymphadenectomy, but not here because everything is so close and it can be risky. He doesn't want to do systemic therapy because it is T2 and it could be N0. This was about 11 years back. So what do we do? Avoiding these situations is always better, and that is the reason why we should become aware. Someone who has done this very early, and rectal cancer treatment across the spectrum of institutions has improved because of his great work. And something like that was waiting to happen in colonic cancer. Because rectum also has an advantage that most of the nodes are within the rectal wall or the mesorectal fascia. The areas of dissection, fusion planes are all very close to the rectum. So it's a little more easier to achieve this. Originally, rectal cancer was worse than colon cancer as far as the overall results are concerned. But later on, after the TME was described, rectal cancer has become much better for multiple reasons. One is TME, then MRI has been very useful, unlike in colon cancer. Preoperative therapy, both radiotherapy and chemotherapy have come into existence. And then better surgical dissections and multidisciplinary approach. Why not in colon cancer? I'll skip all this because I have a very difficult school headmaster here with a bell there. Chandramohan and Madhu called it a video lecture, so I'll just go there with a tribute to the Japanese group and the German group. Defining them is not really necessary. Eventually, what is important is both are actually almost the same, except that the segment of bowel removed in Japan is smaller than the West. So we need to understand that nodes, mesocolon, vessels all have to be dealt carefully. Multiple studies are there proving that there is a disease-free advantage and an overall survival. Which surgical procedure, extension of a surgical procedure, like a lymphadenectomy has given a 6% survival advantage, you would really need to search to get an answer for that. So we started with low ligations like this before we understood that actually complete lymphadenectomies are useful, and then NCCN and AJCC did not talk about 12 nodes. They would not even count number of nodes for the TNM itself. So now the pressure on the surgeon has increased. Even for a patient like this, we would do a low ligation, especially in minimal access surgery, when we were actually learning. So we would leave the left colic artery uniformly and in all patients. We would do a ligation, and we would definitely do a mesocolic excision, but not a good central vessel ligation. And then as things evolved, we started going to the root. Even in a post-radiation scenario like this, painstaking dissection it can be, but it's something that was achieved a little later on. For the right colon again, we started with D2. in the early 2000, and when there were nodes, when there were nodes, pericolic nodes that were visible, we would do what I would call it D2.5, wherein a part of the vein only was actually seen before we clipped these vessels. Old analog single chip videos. And when you have so many nodes like this, a bulky node there, and multiple nodes that are actually seen through the peritoneum in a thin patient, you cannot possibly leave these nodes while you are dissecting. So that's what actually stimulated us to extend onto the vein and onto the artery to clear all these nodes for fear of one of those nodes being positive. So it was not by principle but by necessity that we have done D3 lymphadenectomies. When you call the CME plane here, it's not as easy as the rectum, but it's something that can be achieved, especially in minimal access surgery, because you have a tangential vision. You can flip the scope and see in multiple directions, and the difference in the color of the fat is something that will always guide you to the facial layers. So as long as you stick to your vessels and the plane, these things open very easily. And the other important thing is not to allow these patients to bleed. What's happening? Oh, you really skipped a lot of videos, but anyway, it's all right. Come. They're playing? No. No, it's gone to the next one again. Okay. Whatever. Anyway, we have understood the CME and the CBL first, and then CME and CBL initially permitted a centimeter beyond the root as a ligature point, and that was good for us because we were ligating on the right side or in front of the vein initially. But with D3 coming up, wherein you are actually seeing the artery and going up to the root, the challenges became sequentially more. So that's when actually I had dissected to the right side, holding the ileocolic window and getting into the V of the SMV and ileocolics, but revised that on the same patient because I found a node there and came straight onto the SMV. Initially, there was a fear of the SMV itself. So once we did this, we understood that this is so much more simpler than playing on the right side of it, because there can be small veins on both sides of the vein which can disturb you. If you are in front of the vessel, it's so much more easier, so much more less vascular. And there can be multiple vascular anomalies here, especially the right colic may be absent, can take off from anywhere. It can be very close to the ileocolic artery, and it can be a recipe for disaster if you don't identify it. And that identification is done only if you go onto the vein first. Otherwise, there is a chance that the clip can directly get onto the right colic vessel. Loop of Henle is the worst. Oh, what happened? Loop of Henle troubles everybody, it's troubling me also. Oh. I don't know. That was the best video actually, because it didn't play. Honestly, it was the best video. It's beautifully dissected. The two videos, very well dissected. Anyway, it's all right. Middle colics, they're not playing. Oh God. Can I play from the other one? From the hard disk? No. नहीं मुश्किल होता है. There are quite a few. No, not that one. The SSD.
Small one.
SSD is with him. They played there actually. I don't know what's happening. a good D3 lymphadenectomy. And you keep seeing nodes on this only if you actually reach there. And there are situations when those nodes only are positive. Highlights the CBL plane there. You are in front of the pancreas, the loop of Henle, the right colic vein, and a venule that is joining the right colic vein. Devascularize the colon sequentially before you go up. Middle colic also can be challenging because you would most often need to dissect between the two, the V of the middle colics. And if you are standing on the left side of the patient, you may have to shift between the legs of the patient to do this part much better than otherwise. Because your ergonomics, the right hand will not reach the middle colics easily and perpendicular to the vessel. You will be parallel to the vessel and it can be trouble. So it's always good to have a split leg position and then move between the legs of the patient. Gastroeploic part, if you have an hepatic flexure lesion or a high ascending colon lesion, gastroeploic nodes, the number 6 of the gastric nodes have to be dissected close to the gastroeploic pedicle, and you keep seeing nodes here. So by principle, you do this for every patient. Yes, he has become active. And then flip it on the other side. See behind the whole thing has been dissected clean, and that is called a CBL plane, CME plane. And then continue on the subeploic dissection and complete it. That's how it looks. At the end of it, absolutely nothing that remains. And that's how the colon, the right hemicolectomy bed looks. This is for the left colon. Okay. Anyway, I don't know. They're not working. There's a lot of lag because they're all 4K videos. The file is about 60 GB, so it's expected that it will not play. Yeah. It would have played on my laptop. Okay, I'll conclude. Anyway, the bell is on. What do I do now? End slideshow. Go down. Go to the last slide. They're not there. Come here. No. Important here is to stick to a plane discipline in surgery, lane discipline in traffic. And I don't know if you remember him, he passed away, one of the greatest comedians you would have ever seen. He went to US to drive as a driver. Most of them are very good at it. So the interviewer asked him, you drove in Punjab and you drove in US. Here it's all left-sided, there it's right-sided. Did you not have any problem? So the Sardar replied, I would drive in the middle of the road here. I continue to drive in the middle of the road there also. So nothing has changed for me. For such people, it doesn't matter, but for others, I think you should maintain a lane discipline. CME, CBL, and D3 are essentially the same. Surgical procedure, one surgical procedure with a disease-free and an overall survival advantage. Morbidity in high-volume centers is not different from D2 and less. And it really gives you surgical ecstasy to see these vessels and work on them on a daily basis. That's all. Thank you very much. I have borrowed this from Senthil Rajappa. This is how Hyderabad is. He is so dangerous. And, he can afford to be risky for himself, but for everybody, he is risky. That's where I hail from. Trivandrum is much better. Thank you very much. Still be kind to us. Thank you.
Thank you, sir. Thank you, as usual, for those interesting collection of videos. And just to start a discussion with the one technical point is, so when we talk of the D3 dissection along the ileocholic vessels, so vein is straightforward, you come up to the origin. The challenge sometimes comes when the ileocholic artery travels posterior to the SMV. So ideally, in that case, you need to loop the SMV and then go to the... So do you recommend that, or is it to be done in all cases?
No, if there is nodal disease there, while you have done the anterior dissection, you start on the on the right side, right third of the artery, and then if there are really nodes there, I have done it. But otherwise not. But otherwise, it becomes too much of an exercise. And it's feasible.
But by definition, so what do you call that? That type of, if you take the ileocholic vessel, when it ileocholic artery, when it travels posterior to the SMV.
I would not call it D3 actually. Yeah, I would not call it D3. I'll call it CME, CVL.
Okay.
Nice videos. So if I can make a provocative statement, do you think this is a rethink about D3 and central venous ligation, although it was there in rectum, regarding colon came up because of better imaging techniques, better technology for lab vision, minimal access. Do you think that drove it partly?
I don't know if it has driven it, but I think if there is a local recurrence,
no, if you can get 12 lymph nodes
to the extent of 14%,
if you can get 12 lymph nodes without a D3.
No, you are not chasing the number of lymph nodes to convince the pathologist or convince the patient. I don't think it's that way, because what is said is, even if they are negative, when you dissect more number of lymph nodes, those patients have actually done better. Okay. So it's not convincing somebody. That's also a small part of it, but because it's the only way you can assess lymphadenectomies of different surgeons. It's a criteria for assessment, and I don't think beyond a certain stage you should even be thinking about the number.
Yeah, from house.
Sir, a good question, which I don't understand. Because someone has done not a good colectomy, he's done a D2 colectomy, a patient comes to you, inadequate lymph nodes or whatever. But okay, so what would you do? Would you do a redo colectomy? Not after treatment, suppose after 1 month or so. Or would you give adjuvant chemotherapy?
I would change the medical oncologist and give adjuvant chemotherapy.
No, I'm telling you, because there are so many of you from the ISO, so I've submitted an article there, okay. So we look many of these right colons who come and we'll give them adjuvant chemotherapy. But the outcome of these, which are suboptimally done colectomy, is really bad. They come back with the recurrences despite adjuvant chemotherapy. So adjuvant chemotherapy is not a solution to inadequately done thing. So they have 40% incidence of peritoneal disease and recurrence rates are very high. So all in all,
go back in.
Please accept the paper.
No, Avanish, in that situation, see, 13th day I told you, would you give some chemotherapy and go back in? What would be the good strategy? Because
I think if it was only day 1, I think we would go back in at about 6 weeks or so.
Day 1 क्यों आएंगे आपके पास?
नहीं आते. The general surgeons do it. They do it at emergencies and things like that.
Okay.
But I think, obviously, improvement
how to strategize, basically. I also want to do a lymphadenectomy in this patient.
Yeah.
I also want to.
We don't know, because it's only the dangers of doing it. But sometimes when you do redo surgery, then you see they have not addressed the ileocholic pedicle itself, and things like that. So we don't have an answer. But the outcome of those inadequate treated ones are really bad, despite adjuvant chemotherapy. So we can have a look at it.
D3 is defined, nothing else is defined, is it not?
I know.
Yes.
Sir, you were asking what is the reason. Is it because of the rectal cancers? Yes, definitely it's understanding of the anatomy and visualization And to some extent, we are all in the process of evolution. We know the biology is also different. So if you attack more number of nodes, the yield of, as he was trying to say, 12 is not the number. The more the number of the yield of the nodes is better, the results have been proven to be better. So now we know if you go along the planes, actually, Rao was trying to say, actually, if you go along the planes, it's more easier to dissect and go. So you naturally you get one plane in that area, and then it becomes more easier also.
Central vascular ligation actually directly gives you the plane.
Better vision.
Yeah, obviously, sir. Obviously. Or else we will not venture into such things. See, we ventured there, and the nerves, everything was seen. So just the turning of the camera this side, and it has become more comfortable here.
Okay. We did a small observational study, prospective study. One of our residents had done that study of maybe 150 cases of D3 dissection. And I never expected this result, about 9% positivity. Not that the numbers increased, the positivity at the D3 station was 9%. So I think that 9% justifies the need to do a D3 dissection. Probably we had to look at whether this 9% positive patients would translate into survival.
Better survival also.
Yeah, this is a short-term study, immediate post-op outcome. So 9% positivity is still there, which I was not expecting, 9%.
Rudra would remember, we operated on a senior surgeon, left colon, splenic flexure lesion. Most difficult D3 is splenic flexure because the vein comes in an angular fashion and joins the IMV just before the IMV joins the splenic vein. And in the patient's position and our position that you are in, to reach the splenic vein there is not easy at all in really obese patient. So actually the next videos actually show a lateral approach to complete the medial approach and then go for the SMV laterally, mobilize the colon. And for that patient, the only node that was positive was, which was at the fork of IMV and the splenic vein. So if we had not painstakingly dissected that node, we would have missed the only node and we would have called it N0, and the patient would have been grossly understaged, a surgeon himself. So you need to be meticulous. You want to help a few more patients, and those are the only few patients that we all cure. So don't leave them. Thank you.